Okay, sir. Ready? Okay. Hello. Hello. Please start. Right. Just cross. Topic. Direct questions. English. Like questions level. శివగారు స్టార్ట్ చేయలే కదా కాదు సార్ క్వశ్చన్స్ ఏమైనా ఉంటాయని ఎట్లా తెలుస్తుంది సార్ క్వశ్చన్స్ అండి క్వశ్చన్స్ క్వశ్చన్స్ కావాలంటే క్వశ్చన్స్ ఏమైనా ఉంటే సార్ వాటికి ఆన్సర్ చేస్తాను స్టార్ట్ Okay. Good afternoon, all of you. We're just having this session. I am Dr. VijayKumar. I'm the head of the surgical gastroenterology and minimal access and robotic science at Keyhole Hospital, Kondapur. Today, I wanted to address and interact with all of you regarding one of the most common problems that we come across, that is hernia. The hernia is a very common term. It could mean many things. Hernia at very different places, and it's different in both men and women. So basically, hernia is an abnormal protrusion of a part or of a part of the body into anatomical orifices. So in the sense that it's an abnormal protrusion of the internal organs. The most common hernias that you get in men is the inguinal hernia, and in women it is the ventral hernia, what we call as the it's broad terminology ventral hernia. That you can have umbilical hernia, you can have the gastric hernia, and you can have hernia after any surgeries. So what happens in these hernias is that there will be a small defect, which is either a natural defect or it could be defect as a result of some previous surgery. And this defect creates an opportunity for the organs which are into the abdominal cavity to protrude to the exterior, which is not otherwise normal. So when such a process occurs, wherein some structures which are supposed to be inside the abdomen, if they start protruding outside the abdomen through a naturally present orifice or through an orifice which has been created due to a previous surgery, then it is called as a hernia. So when I say natural orifice and the orifice which is created or defect which is created post a surgery, is say for example in when there is this inguinal hernia. That means in the groin there is a natural pathway which is provided by the nature, wherein the spermatic cord and the blood vessels to the testis pass through that small defect from the abdomen into the scrotum. So this is a natural orifice which is available, and that is available only for the spar structures to be going down into the scrotum. But what happens is, due to many causes, this defect widens, this pathway widens, and then the intestines, which are supposed to be within the abdominal cavity, they start to descend into the groin, or it may also descend into the scrotum. That is when it is called as an inguinal hernia. So there are a few other places in the groin where hernias can occur. It is called as inguinal hernia, it is femoral hernia, obturator hernia, and in inguinal hernia it could be a direct or indirect. So although groin is a very small area, but there are 4 or 3 potential areas through which the organs or the intestines which are in the abdominal cavity have a tendency to protrude through that defect into the exterior. It could be confined within the groin, or it could descend into the scrotum in men. So that is a natural orifice or natural pathway which is present, but it has gone beyond taking only the cord, and it also allows the intestines to get into the exterior. That's an inguinal hernia. So when I say orifices which are being created due to previous surgery, for example, if anyone has gotten a surgery on the abdomen in the past, say most commonly when what we get in females is a caesarean section. So when there is a caesarean section or a hysterectomy or any other open abdominal surgery, so the abdomen is opened, the surgery is performed, and then the abdomen is closed with different layers, various layers. So when the internal layer, that is the rectus sheath and the rectus muscles, this is a very important structure or one of the layer in the abdominal right wall. So this actually provides the strength to the abdominal wall. The reason most of our intestines are within the abdomen and they are not coming out is because whole abdomen is covered by this rectus sheath, which is tightly held by the rectus muscle. So when you do a surgery, we have to cut this rectus sheath and then we have to get inside the abdomen to perform whatever procedure we have intended. So when we close this rectus sheath, again due to various reasons, which I will discuss in a short while, due to various reasons, one of the opening happens in this sheath. So the sheath is closed like this, and then a hole occurs in that part of the sheath. It could be a loose stitch, or it could be an opening from there. So what happens is the intestines start protruding through this small hole into the subcutaneous tissue or under the skin. So that becomes a hernia. It is called as the incisional hernia, or broadly it can be called as a ventral hernia. This is due to a orifice or a defect which is created due to a previous surgery. Same thing is umbilicus. Umbilicus is the weakest spot in the anterabdominal wall. This is where the sheath is weakly linked with the opposite side. So this has got a tendency to develop a hernia. So if there is obesity, especially the truncal obesity, if the abdominal fat starts increasing too much, and if there is too much of weight gain, then this is the weakest point, and so the umbilicus becomes a little wider, and you can see that your umbilicus starts bulging. Normally, umbilicus is a flat, or rather, it's slightly inverted. But when the umbilicus becomes flat or it becomes inverted, and you can see some small bulges within the umbilicus when you are walking, getting up, and when you lie down, it goes inside. So that is an early sign that you are developing an umbilical hernia. This can also happen post pregnancy. In pregnancy, as you know, the abdomen gets distended, so this is the weakest point. So this also gets opened up, and a hernia can occur there. So this is called as an umbilical hernia. So this umbilical hernia or incisional hernia post any surgeries, or sometimes even otherwise, whether there is weakness in some parts of the abdominal muscles, the parietal hernias we call them. So those hernias can occur. So all these hernias put together on the abdominal cavity, we call them as a ventral hernia because of the ventral side of the body. So ventral hernias. So what are the causes for this hernia? I just told you briefly what are the different types of hernias. Most of you must have come across or heard or read about the hiatus hernia. Okay, hiatus hernia is detected when an endoscopy is done, and all those patients who have symptoms of acidity, acid peptic disease, when they do an endoscopy, the endoscopy report would have said small hiatus hernia, medium hiatus hernia, large hiatus hernia, and as symptoms of esophagitis and all. So that hiatus hernia is a different hernia. That is not a hernia which is protruding outside the abdominal wall, which I mentioned now. That's a hernia which is an internal hernia. There are other causes and other types of internal hernias which I will not discuss in this session because it will be too much beyond the scope of the understanding of common people. So that is a hiatus hernia. Don't confuse hiatus hernia with one of these ventral hernias, and then don't get panic, rush to a doctor. So if you have a symptoms, then that hiatus hernia will be treated according to medicines or so on and so forth. So there are the different types where a hernia can occur in men and women. In men, the most common type of hernia is inguinal hernia. In women, the most common hernia they come across is ventral hernia. incisional hernia like post-caesarean section, post-hysterectomy, or it could be umbilical hernia. So these are types of hernias. So what are the causes of these hernias to occur? As I said, if you look at the ventral hernias or the incisional hernias, the definite cause is the antecedent previous surgery. So having undergone a surgery in the past itself doesn't qualify you to get a hernia. There are many factors which add on to this causing a hernia. Like you have had most of the patients should have had surgery some 8 years, 10 years back. If during that surgery or immediately after that surgery, if you had a wound infection, that means your stitches had an infection and the stitches were partly opened up. That means there was infection at that point of time. So when there is infection, this infection carries down to with the sheath also. So the stitches which were put over the sheath and the rectus muscle at that time would have been weakened. So which part of the sheath has become weak is different in different people. So this presents as a hernia much later. So this is one of the common cause that if during the surgery, if the sheath was not closed properly. So when we want to know the causes, we define them into patient factors, we define them into disease factors, and we define them into the technical factors. When you say patient factors, if the patient is elderly patient, obese, lot of frontal obesity, lot of fat in the abdomen, if the muscles are very weak in that person, or the patient has got some neuromuscular abnormality by which his muscles are very weak, then the strength of the muscles is not good enough for the sheath which is very close to heal well. So these are the one is this wound infection. So patient factors again important thing is if after a surgery, immediately after a surgery, the patient has had some factors which have increased the intraabdominal pressure. Say the patient has had a bad cough, is a constipation, lifting heavy weights. All these increase the intraabdominal pressure, which make these um, stitches which have been very recent to open up. So that is why if you say in the past after a major abdominal surgery where an open surgery was performed, patients were advised just for a month and a half. The reason being that the sheath and the rectus muscle which have been closed with the sutures, they should heal well. So this healing takes 4 to 6 weeks to give adequate strength to that legs. So that is why they would have advised to avoid lifting heavy weights, do the instruments activities. So if you get a cough, you get the cough treated immediately. If you have a constipation, you should get the constipation treated quickly, so that there is no factor which causes increase in the intra-abdominal pressure, whereby it leads to a tendency to form herniation there. So these are the patient factors. If you come to the disease factor, if the disease itself is such that the chances of causation of hernia is high, like if there's an infection, intra-abdominal infection, or if there has been an infection during the surgery, like if there's a contaminated abdomen, if there's a hole in the intestine, perforation in the intestine. So those are the ones where there is a chance of herniation. Those patients are at high risk of developing hernias. That is, those who have had bad infections during the primary surgery. Primary surgery is not the first surgery, maybe a caesarean section, hysterectomy, many other open abdominal surgery. So if they had a history of wound infection at that time, then yes, this patient is likely to develop a hernia in future. So that is when a lot of precautions are to be taken. You have to give support to the abdominal wall by using abdominal binders or belts, they call this. You should avoid lifting heavy weights. You should avoid strenuous activities. Not treat or prevent cough and constipation. So as I said, the factors which increase the intraabdominal pressure. So these are basic factors. Then there is a technical factor. That means if the closure of the sheath and the muscle is not done properly, so then that definitely becomes a weak abdominal wall. So the chance of that patient developing hernia will be very high. So these are few of the causes in a ventral hernia. In inguinal hernia, it is different. In men, that could be a congenital or a acquired hernia. Congenital hernia is that, as I said, since birth, as the testis descends from the abdomen into the scrotum, it is taken down by this spermatic cord. So a small defect, a small opening is created in the groin through which this cord goes down and the testis is landed in the scrotum. But during birth itself, if this opening is very wide, instead of allowing only the spermatic cord, it has enough space to allow some other contents also, like the intestines. So this becomes a congenital hernia. That means the propensity for this patient, for a patient to develop hernia, has been created since birth. So that is a congenital hernia. But if the since birth it has been very proper, the defect or the opening in the groin is adequate enough only to allow the cord. As the age progresses, if the muscles are weak, especially we have this in old age, people who are old age, the muscles naturally become weak. Then this defect becomes bigger, and there could be a hernia to the groin into the scrotum. It's not only related to age. Some of the men who are strenuous workers, athletes, heavy weight lifters, these patients can also develop hernia. So these are the acquired causes. It means some of them who are heavy weight lifters. That's why you see that most of the heavy weight lifters they use adequate padding in the lower abdomen. That is precisely to prevent hernias. So these are the causes of hernias in men. That is a human hernia in men. So that is why when a patient comes or someone has got a hernia, it could be a vertical hernia in females or human hernia or vertical hernia in men. Men also do develop umbilical hernias because of obesity. They do not notice it, or they notice it, but they feel that it is fine, it is not abnormal. So then the chance of that hernia becoming very wide is high. So these are the various different causes where a hernia can develop. So it is important to know what cause has been there for a particular patient who has got a hernia. So if you notice any of such things in your body where your umbilicus is protruded and it is inverted and you can see some bulge, that means it is not normal. It is an umbilical hernia. How big is the umbilical hernia? What needs to be done for these hernias? That is a different issue which we will discuss in the aspect of this. So basically, these are the causes of this hernia. So if you notice that there is a bulge in your abdomen, either in the umbilicus or in the supraumbilical region, in the chest and the umbilicus, there is a swelling. That is another common site of swelling. Or if you have had a previous surgery and around that scar area or anywhere adjacent to the scar area, if you have had a swelling, then that is a hernia for you. So you should get yourself checked by a doctor and confirm whether it is hernia. Very rarely you will have some obesity, as you said, increased subcutaneous fat also sometimes feels like a lump in some of them. So that has to be differentiated whether it is a hernia or not. Because the reason is that identification of a hernia is important, treatment of hernia is more important because this is one disease which can cause complications and complications can be reasonably weak, but they are very much preventable. So if you identify the hernia at a very early stage when the defect is small, because a hernia will not mm, close on its own. Say umbilicus, if it has opened up, if you're seeing a bulge in umbilicus, there is no way that this bulge is going to go off on its own. Maximum you can do is you can allow it to stay where it is. Say if the defect is 2 centimeters, this defect will never become 1 centimeter or 1.5 centimeters. It will remain 2 centimeters. You can only prevent it from becoming a 3 centimeter or 4 centimeter defect by taking adequate precautions. So, what I'm trying to tell is that basically hernia is a condition which cannot be treated or which cannot be cured by medicines or non-surgical options. The only available best possible effective long-term treatment option for hernia is a surgery. Now we'll discuss what type of surgery, what all things are there. So, but you should all remember that there is no medical line of treatment for hernia. Of course, there could be very small hernias where we say, okay, there is no immediate need for surgery. We can wait, we can observe, take precautions and adequate steps so that the hernia doesn't become big. So this is a very important context. So when you notice any of such abnormal swellings on your abdomen or in the groin, then you should visit a doctor. Most of these hernias are clinical diagnosis. You do not need a big, huge test to tell you whether it's a hernia or not. So it's a very simple test what we do, and that's called as a cough impulse test. When you lie down, if your swelling becomes flat, if there is no swelling, if you cough, then you would see that there is a bulge from that small opening. Either it may be the groin or the umbilicus or your scar area where there is a bulge. If on coughing, if you can see a bulge, that means you have got a hernia. So you do not need any big tests to tell you whether there is a hernia or not. Yeah. So if there is a doubt when you're coughing or you're raising your head while sleeping, then you can see a bulge, but you're very doubtful. And when we examine, if we are not able to clearly identify the cough impulse, then there is a role for doing few investigations. Like the simplest investigation will be good enough for this, like the ultrasonography. Ultrasonography is a very good test. Maximum number of hernias can be detected, and the characters of the hernia can also be told by ultrasonography. So if you have such a doubt, please visit a doctor. He will examine, he or she will examine you and tell you, yes, you have got a hernia, but the defect is so and so. Don't just go by saying that it's a small defect, you don't have symptoms, so just wait and see, nothing will happen, we'll see how it progresses. Do not do that. You should meet an expert who has got experience in treating hernias, because there's common concepts vis-a-vis the guidelines for treating hernias is wide. It is different. Asymptomatic hernias need not be treated is a myth. It is not true. Any hernia, all groin hernias mandatorily need surgery. All incisional hernias mandatorily need surgery. There is a small window of avoiding surgery in few hernias, like a very small umbilical hernia. We say around 7 millimeter to 8 millimeter defect. If you go on ultrasound, if they say there is an umbilical hernia, but the defect is 7 to 8 millimeter, then we can allow these patients to avoid surgery by using adequate precautions. There are some things that you need to do so that you do not allow the hernia to grow bigger. The whole idea of why hernia is so difficult, or why hernia is so sort of threatening that it has to be operated. The reason is what is coming out of the hernia is the intestines. So when the intestines come out and intestines go inside, it is fine. We feel that we don't have much problem. But if the intestines come out and then they don't go inside, then you are in big trouble. This is called as an irreducible hernia. And the next complication will be a obstructed hernia. So these are very dangerous complications. So as long as the hernia is reducible, you are well within um, safe. You are well within the safe margin. So you should not allow any hernias to become irreducible and so what I was telling you is that the reason why treating hernia by surgical means is so important is that once the intestines come out and they don't go inside, they will cause obstruction. That is called as an intestinal obstruction, which is a very acute event. It will need emergency surgery. As per the protocol, we say that any obstructed hernia should be operated at the earliest. As soon as you detect there is an obstructed hernia, the patient in no time, at the earliest possible time, should be on the operating table. So you should not welcome such situations where it becomes so emergency that you do not have any other options, and also the surgery becomes more important in such situations. And intestines being a very important organ, which you can't afford to have obstruction from the intestines. So you are converting a elective surgery into an emergency surgery by not taking action at the appropriate time. That means if you have seen that you have a bulge in one of these areas which we discussed, and if you do not visit a doctor, or you visit a doctor and if there is surgery, and someone tells you that you do not have symptoms, it's a bulge, okay, you can wait and see how it goes, and then you land up in obstruction, then you are the one who is going to face the problem. So do not avoid this. So when you have reached this stage and your doctor says that this is so and so hernia and it needs surgery, plan it. It is not emergency at that point of time. When you have got a hernia, it is not emergency at that point of time. So you plan accordingly, choose the doctor, choose the hospital, and then you get the hernia surgery done. Because in the treatment for that, I'm telling you why to choose the facility where you want to get operated is the amount of treatment options available for hernia in the present day. The conventional way of treating hernia was an open surgery. But the problem with open surgery is, one is it's an open surgery, so that means you will have a lot of sutures, and the duration of hospital stay is more. The duration required for recovery is more. Pain is more. Above all, the chances of recurrence is high. You're getting operated for a hernia because there was a defect and the internal organs were coming out, but you are keeping a threat for it to come back again. That means recurrence. So the chance of recurrence in open surgery is high. The other option is a minimal access surgery. What you call the buttonhole surgery, the keyhole surgery, sutureless surgery, laparoscopic surgery, minimal access surgery. So this is another component of treating hernias, which is, according to me, it's a gold standard now for any hernias. But yes, everyone will not be able to do laparoscopic surgery for open hernia. In that scenario, the doctor may convince you and say that no, open surgery is safe and best for you, we will do the open surgery. So please take another opinion when someone says open surgery. Because in the current day, the amount of surgeries which can be done by minimal access or the keyhole surgeries is enormous. Almost everything we do by minimal access. So when someone says that open surgery is the best for you, please take another opinion and search for a person who has experience in minimal access surgery. So when you reach a hospital in an elective setting, that means I noticed a hernia, we detected a hernia, there you can do it laparoscopically. You can choose your time, you can choose your date of surgery, you can choose the center of your choice, and then you can get the surgery done by minimal access. Please, it's my humble request, do not get hernia surgeries by open method unless it is an emergency or very rare situations. To be very frank, I haven't done any open hernia surgeries in the last 8 or 9 years. We have had many complicated hernias, recurrent hernias, obstructed hernias. As I said, all these complications wherein you need an open surgery. I did mention that if this hernia becomes complicated, you might land up in open surgery. The reason I said that was all centers do not have the expertise to handle complicated hernias by laparoscopy or minimal access. Okay, so there is some limitation of skill, there is some limitation of expertise in this one. So if you land up in emergency and you reach a hospital, and if that center is not very well equipped or experienced or has lack of expertise in doing complicated hernias by minimal access approach, then obviously you will be left with no option but to undergo a open surgery. So that's why I'm telling you that do not get any hernia surgeries by open method unless there's a very, very, very strong reason to do it. There could be few reasons, which I discuss later. So laparoscopy or the minimal access approach is the best approach. And to tell you a step further, I do hernias, all these mental hernias, minimal hernias by robotic method also. Robotic surgery is a more advanced way of minimal access surgery. So robotic surgery is also robotic surgery is not available in all the places. Laparoscopy is available in many places. Robotic surgery is a more precise, more accurate, least complications, very precise way of handling the hernias. It's another variant of a minimal access surgery, okay, but with a lot of safety and precision in that. So this is the I would call a gold standard treatment for hernias is a minimal access approach to hernias. Second thing you must remember is whenever you are visiting a doctor who is offered you a treatment for hernia, you must ask whether it's going to be by minimal access approach. Second is what is the size of the mesh and the type of mesh that he or she is planning to use. So these are the two important components in a hernia surgery. So when you develop hernia or when you have been identified to have hernia, you have to go through few investigations which will make you which will make you your assessment for the fitness for the surgery. So based on that, the treatment will proceed with you. So this is the in nutshell what are the types of hernias, what are the causes of hernias, and what is the treatment. But I'm not telling you in detail about the final aspects of the treatment of hernia because otherwise you get confused. So whenever you go to a doctor, I'm just trying to impress upon you. You should make sure you ask what is the type of hernia you have got, what is the size of the defect in that hernia, and what are the contents of the hernia. And when you are offered treatment, is it minimal access approach? And what is the, as I said, what is the type of mesh that will be used, or what is the size of the mesh that is being used? So there are, why I'm telling this, there are set guidelines which have been laid down for approaching hernias based on the location and the size. So that is what about the hernia. So what happens if you do not get this hernia treated? So there are, say, if you do not get this hernia treated, as I said, it can lead to irreducibility and obstruction. And there's another terminology called as a gangrene of the intestines. So if the intestine comes out of the defect and stays in the abdominal wall, and if it doesn't go inside, it will naturally cause obstruction to the flow of the contents within the intestine. And next time when you eat or drink, you will not be able to digest it, and you start vomiting, and the intestine gets distended. You see a sudden increase in the size of the swelling which was present previously. So that is obstructed. If even if that situation, if it is not treated, or if the defect is very small and the contents are too much, then what happens is the blood vessels which traverse through that defect get compressed. So the blood supply to the intestine, which is lying outside, gets compromised. That means it is sort of you are not allowing the blood to go to the intestines, and then that part of the intestines becomes decayed. That is what we call as a gangrene of the intestines. That is the extreme situation that anyone can reach up to. If someone is reaching till a gangrene, that means there's been enough and high amount of delay and diseases that has been done in reaching that stage. So we have seen many patients who come with obstruction, there will be perforation within the obstruction, there will be gangrene, and there will be multiple defects. There will not be one defect, there will be 4 or 5 defects, and to every defect, the intestines walk outside the abdominal wall. So these are all come under complicated hernias. So this is very big defect. The defect is 3 centimeters versus a defect of 8 centimeters, which makes a huge difference. So how to address those big defects, and is the surgeon having the expertise enough to close those defects and then place a mesh? So there's a small technical factor which I tell you. There are surgeons who do not close the defect. When they do by laparoscopy, they identify that and they just place a mesh across the defect and leave it. But that is not the best approach. The best approach is where you close the defect. If the defect is 3 centimeters, 6 centimeters, 8 centimeters, you do suture the defect and then place a mesh. Suturing the defect needs a lot of expertise and skills. So some of them do not close the defect; they just place a mesh. So there's a chance of the chance of recurrence in them is slightly higher than those who have got their defects closed. And also there is a one postoperative complication called as seroma, which is higher in those patients who have not had their defects closed. So these are the technical aspects of dealing with the hernia. So you should not reach a stage where you develop a complicated hernia. When hernia is small, when hernia is reducible, the outcome will also be equally very good. So that's what I would like to say, that when we have a hernia, do not allow it to become a complicated hernia from a simple hernia. So no hernia is simple here, by the way, but in technical terms, complicated hernia is much more difficult to treat. You have more long recovery time and morbidity, in the sense that some of the smaller problems like a pain or difficulty getting the treatment there. Now, how is this laparoscopic surgery? As all of you, it's very natural that if we offer surgery or if you are told that you need a surgery, the first thing that will happen is you get afraid, you get panic. Oh my God, surgery, I don't know how the complications. Going through the surgery is a big task and pain. Yes, it is. But that is where the refinements in the surgery, the advancements in the surgery, the expertise of the surgeon, the infrastructure all play a role in reducing this panic of yours, in reducing this stress of yours. So nowadays the surgery has become very smooth affair. The anesthesia, the surgery, the hospital stay itself have changed over the last decade or two. So much of refinements have come in the aspect. So nowadays we do not see any, most of the times we do not say any patient so much of, we do not get into so many complications. Earlier, any surgery would have defect meant that there are, it's going to be a complicated affair. It is not so nowadays. Most of these hernias are daycare surgeries nowadays. And we come in the morning, at least our patients here in my center, in our department, they come in the morning, get operated, and then most of them go the next day because we place a mesh and that some amount of pain or discomfort might be there. So most of them are not comfortable staying in the night so that they know what problems they get. And the next day they walk back home. And all of them are back to work by the 4th of the day, max 14. So what I'm telling is there is no need to have the fear if you're offered a surgery. We have seen patients who come with a complicated hernia, big hernia, multiple defects, and when I go through their medical record, I know that 2 or 3 years back, already this patient had a sonography done, there was a hernia detected, and the patient was advised surgery. And when you ask, the patient says that I was advised surgery, but I was very afraid at that time, and it was a very small hernia, I had no symptoms at all. So I didn't want to go through that surgery, I postponed. And now the patient has ended up in big hernia. And big hernias are always going to be a little difficult to treat, and it comes with a little bit of more discomfort than a simple hernia. So the reason I chose this topic today and to impress upon you the importance of hernia being treated is this, because I see a lot of complicated hernias. I do see recurrent hernias. I do a lot of recurrent hernias. Recurrent hernias in the sense that the patient had a hernia, it was operated either by open or laparoscopic technique, and then there is a recurrence in that. There are a lot of reasons for that. I'm not going to that. So when I see recurrent hernias or complicated hernias, so then we know that this could have been operated when it was a simple hernia, small hernia, like that. So do not have any fear of the surgery for hernias, and I always again insist try to get the hernia surgery by minimal access approach and only minimal access approach. Unless you are at the best of the centers, best of the hands, very experienced surgeon who has a lot of experience in minimal access surgery, and that surgeon is telling you that this cannot be done on minimal access way, then you might have that situation where open hernia is the only option. So that is in a nutshell about the hernia, the causes, the types, and the complications, and the available treatment options. Okay. For this, no,